the American Association of Clinical Endocrinologists, way back in 2013, they basically base their guidelines upon the entry level or HbA1.
Magnu, for covering this difficult topic in very specific time of 15 minutes. The questions will be taking at the end of all the three presentations. Is it okay for you?
Okay, no issues.
Okay. So I request my co-chairperson, Dr. Daria, to take over.
Thank you so much, sir. Thank you so much. So our next speaker is Dr. A.K. Virmani, sir. He is a well-known consultant physician from Jamshedpur, Jharkhand. He is the chairman, Indian Association of Clinical Medicine, Jharkhand chapter, and he is a vice president, Clinical Cardio-Diabetes Society of India, and he is the regional faculty for PHFI, Public Health Foundation of India, for CCBDM, CCGDM, ACMDC, and CCMTD. And he is faculty in the School of Diabetes at Diabetes of India. So without wasting time, I must invite Dr. A.K. Virmani, sir, for his talk. Over to Dr. Virmani, sir.
Yeah, thank you, sir. Just a minute, I'm just sharing.
Yes, sir.
I think my slides are visible.
Yes, sir, it's visible. Go ahead, sir.
Okay. Good evening to all of you, honorable chairpersons and dear friends. It's wonderful to be here in the virtual conference of RSSDI, and I thank Dr. Bansi Sabu, the dynamic president, for always giving me a topic which is absolutely out of the box. And what I'll be discussing today is there a link between severe hypoglycemic event and a cardiovascular event? And if there is a link, what is the so-called complex relationship? Now, the roadmap to my talk today is I'll just define what is hypoglycemia and what is its impact. What is the relationship of a severe hypoglycemic event to a cardiovascular event? What evidence we have from clinical trials, and ultimately, what are the clinical implications and conclusions? Now, we all know that the hypoglycemia has been divided into three levels. Level 1 is when glucose is less than 70 but more than 54 milligram per percent. Level 2 is glucose is less than 54 milligram. And level 3 is a severe event characterized by altered mental and or physical status requiring assistance for treatment of hypoglycemia. And it is on level 3 that I'll be concentrating in my talk. Now, we all know hypoglycemia has an impact on the multiple organs. It can lead to cognitive dysfunction, blackout, seizures, comas, and psychological effects affecting the brain. And the musculoskeletal system, there are falls, accidents, driving accidents, fractures, dislocations. In the circulation, there is inflammation, blood coagulation abnormalities, hemodynamic changes, endothelial dysfunction, and in the heart, there is an increased risk of myocardial ischemia and cardiac arrhythmias. Now, God has given us a wonderful gift, the counter-regulatory hormone response. When the blood sugar is 82 milligram per cent, there is inhibition of endogenous insulin secretion. At around 70, the two counter-regulatory hormones, glucagon and catecholamines, are released. Between 50 to 60, we have onset of autonomic and neuroclaptinic symptoms. Around 50 is cognitive dysfunction. And if the sugar falls to less than 30, patient is likely to go into a seizure or a coma. Now, the hemodynamic changes associated with hypoglycemia, that there is an tachycardia with increase in the peripheral systolic blood pressure. There is a fall in the central blood pressure. There is a reduced peripheral arterial resistance and hence a widening of pulse pressure. And there is increased myocardial contractility, stroke volume, and cardiac output. Now, what it basically means that there is a temporary but marked increase in the workload of the heart. And this transient cardiac stress is unlikely to be of serious functional importance in apparently healthy young people who have a normal cardiovascular system, but may have dangerous consequences in many older people with diabetes, especially longer duration of diabetes, and those who have underlying coronary artery disease. Now, the problem there is an increased risk of cardiac arrhythmias due to abnormal prolonged cardiac repolarization, that is enlargement of the increase in the QTC interval and cardiac death. Now, what are the basic mechanisms we look by? We have to have know how it is causing. Inflammation is a very important thing. Due to hypoglycemia, there is increase in the procytokines like CRP, VEGF, and interleukin 6. Then we have an endothelial dysfunction leading to vasoconstriction. Then we have a enormous sympathoadrenal response leading to rhythm abnormalities, heart rate variability, and on the other hand, hemodynamic changes with increase in adrenaline, increased contractility, increase in the oxygen consumption, and increase in the workload. And then there is a procoagulant state with blood coagulation abnormalities, increase in factor 7, platelet activation, and increased neutrophil activation. So what is happening? We have abnormal cardiac repolarization, and this is because of the QT interval prolongation, increased plasma epinephrine, norepinephrine, and associated hypokalemia. We have reduced myocardial perfusion. There are hemodynamic changes with increase to cardiac workload and heart rate, a fall in the central arterial pressure and large vessel elasticity. And increased endothelial dysfunction inflammation leads to accelerated atherosclerosis. And we have, as I said, a prothrombotic state with increased platelet aggregation and increased coagulation. Now, the problem here is if you look, and you can only find out a relationship if you are going to do a continuous glucose monitoring along with the Holter monitoring. That is the important way that we can detect any changes. And even we know when patients have chest pain and angina, there are ECG changes seen. But even in patients who are asymptomatic and have hypoglycemia also show ECG changes. And this is what a normal T wave looks like, the QT interval. And when these patients have kalemia and what is happening, hypoglycemia, look at the prominent U wave and flattening of the T wave and increase QT interval because of the hypokalemia as there is enormous release of the catecholamines. And this leads to what is cardiac arrhythmias, various abnormal heart rhythm, including VT and atrial fibrillation. And this is what I'm talking about. And this is a case, a 63-year-old male with documented stenosis of internal cerebral artery, long duration diabetes, 12 years. He was on 22 units of glargine at bedtime. And we recorded the glucose monitoring as well as the Holter. And we see when the patient has hypoglycemia, there are significant ECG changes. And the commonest cause of hypoglycemia in type 2 diabetes is insulin therapy. Now, the insulin therapy, not only are the total hypoglycemic events increase, but we also see a very large increase in severe hypoglycemia. And this has been shown both in retrospective and prospective studies. We all know that intensive glycemic control improves or it benefits both the microvascular complications and the macrovascular complications later on. But the problem is that this intervention works at a price. If you look at the DCCG type 1, as it brings down the A1C, the number of severe hypoglycemic episodes increase. And similarly, in the UKPD study in type 2 diabetes, with longer duration of diabetes and those requiring insulin, there is a higher rate of severe hypoglycemic events. Now, another study, this is the bezafibrate infarction prevention study with more than 14,000 patients, 8-year follow-up. Hypoglycemia was a predictor of increased all-cause mortality. The hazard ratio is 84%. In the Veterans Affairs Cooperative Study on Glycemic Control and Complications, there were more cardiac events were documented in patients with intensive glycemic control versus the standard control, 32 versus 20%. So if you look at the three classical trials, the ACCORD, the ADVANCE, and the VET trial, all had increased severe hypoglycemic events. But if you see the ADVANCE trial, in these, the patients who had much less severe hypoglycemia. And why was it? It was because this patient had a short duration of diabetes, and they had a lower A1C at the entry, and there was very little use of insulin. And these patients compared to the intensive arm. But in the ACCORD trial, which was prematurely terminated, the problem was that even though there was a higher mortality in the intensive control arm, the mortality in those patients with severe hypoglycemia was not that high. So that raised a big query whether did hypoglycemia cause the increased mortality. But we know that severe hypoglycemia is strongly associated with increased risk of various adverse clinical outcomes. So the conclusion drawn was that severe hypoglycemia may either contribute to these outcomes or it may alternatively be a marker of vulnerability to these events. And in this ACCORD trial, the severe hypoglycemia was defined as requiring medical or paramedical attention in which there was either a documented capillary glucose of less than 50 or in which there was prompt recovery with intravenous glucose or glucagon. So severe hypoglycemic events requiring third-party assistance have remained a major challenge, complicating diabetes therapy in the post-2008 era of CVOTs mandated by US FDA for all new anti-diabetic drugs. Post-hoc analysis of several CVOTs have shown that these severe hypoglycemic events are associated with an increased risk of subsequent cardiovascular and all-cause mortality. The problem is it is unclear to what extent they play a causative role and whether it is a risk marker or a direct causal effect still remains controversial. But there is a strong reverse association in which non-fatal cardiovascular events are associated with a subsequent increased risk of severe hypoglycemic events. That has also been demonstrated in the TLICOS trial. So there exists a robust bidirectional association confirming a greater risk of severe hypoglycemic event after a cardiovascular event, as well as a greater risk of cardiovascular event or all-cause death after a severe hypoglycemic event. So what do we draw the conclusion from this? That there exists a patient who is at polymorbid, who is potentially frail type 2 diabetic, and this is the special phenotype who is susceptible or vulnerable to both a severe hypoglycemic event and a cardiovascular event. Now, these vulnerable patients with high comorbidity scores after a first cardiovascular event who are having heart failure, advanced kidney disease, older age, longer duration of diabetes, usually on insulin and that to higher doses, they require a careful consideration of this complex relationship. So to conclude, whether severe hypoglycemia is a major causal factor for a cardiovascular event or is a marker of vulnerability to these events is a matter of controversy. But what is known is that severe hypoglycemia can reduce myocardial perfusion and trigger cardiac arrhythmias, leading to a cardiovascular event, probably in interaction with other risk factors. The vulnerable patients with cardiovascular disease or at high cardiac risk are more likely to have a cardiovascular event with severe hypoglycemia is evident from the intensive glycemic control from the current cardiovascular trials. Moreover, their bidirectional relationship indicates that there also exists a greater risk of severe hypoglycemia in those patients who have established atherosclerotic cardiovascular disease or high risk or at high risk. So what is the clinical implication? It's very simple. The intensity of glycemic control should be individualized in vulnerable patients at a high cardiac risk. These are the patients where we have to be very careful the way we make the glycemic control, at what levels we want to go, and how intense is our treatment. Thank you for a patient hearing.
Thank you so much, Virmani sir, for your comprehensive talk between the bidirectional relationship between ASCVD and hypoglycemia. So we'll take the question answer after the third session.
Sure.
Now I would like to invite Ajit sir for next session to introduce our speaker. Kindly Ajit sir.
Hello. Cardiovascular disease complications is